All right. Hi, everyone. Welcome to the session Smoking Cessation and OAT Care. My name is Anastasia, and I'll be your moderator. We'll get started in just a minute, but a couple things to mention first. This is today's final session. I'm sure you will be getting an evaluation form after this. Please fill it out. We'd really appreciate it. You should feel free to ask questions throughout the presentation. Peter and I will be keeping an eye on the chat, and he'll be taking questions as he goes. And if you're having any technical issues or you need any support, let us know in the chat. Conference services and I will do our best to sort things out for you. So now I'd like to introduce Dr. Peter Selby. He is the PI of Intrepid Lab and a senior scientist of addictions at the Center for Addiction and Mental Health. He's also the vice chair research and Giblin professor in family medicine at the University of Toronto, director of Addictions and Mental Health Division, University of Toronto, and a professor of psychiatry and of the Dalla Lana School of Public Health at the University of Toronto. Let's welcome Dr. Peter Selby.
Thank you so much for that kind introduction, Anastasia. Thank you, everybody, for being here on a Friday afternoon. And as Anastasia said, please feel free to tap in and type in your answers, type in your questions. I'll try to, or your comments, and I will certainly try to get through them as we go along. So in terms of disclosures, my disclosures are many. I'm funded by the University of Toronto in this professorship. I've had grants. This is my lifetime of grants from various organizations, private, not-for-profit, and speaking engagements as well from private and not-for-profit, no consulting fees. And because I run a large program in Ontario for smoking cessation, where we buy drugs, this is a Ministry of Health funded program called the STOP program. We buy medications, NRT, for patients. And so we get that through an open tender process through CAMH. But we do get a discount from these companies, Johnson & Johnson, Novartis, and Pfizer. And Johnson & Johnson now is called Kenvue, which is their consumer division. No tobacco, vaping, or alcohol or food industry funding. And with respect to opioids, I don't work with any of the manufacturers of medications to treat OUD, and have been very heavily involved in the development of guidelines for the treatment of OUD, very heavily involved in in the book that we produced at CAMH for the management of OUD. So I'm going to do a land acknowledgement next, but actually today, this is the land where CAMH is situated in what is now known as Toronto, but and is covered under the treaty number 13 of 1805 with the Mississaugas of the Credit. But I am actually joining you today from New Jersey, which was the home of the Lenape people. And it was the Lenape people's culture and ancestrals' homeland that I am sitting and joining you from there. And this place where I'm at was the ancestral homeland for over 14,000 years. And they were forcibly removed and displaced by European colonizers, resulting in a historic diaspora. So some tribal and First Nations here, officially recognized by the state and federally maintained communities that still thrive today, located throughout North America, New Jersey, and the greater Mid-Atlantic region. And if anybody is interested, there's a great podcast called Empire. And this current season is on the America and the colonization of America. And it's really fascinating to hear it from a historical perspective as opposed to what is commonly taught to us. But returning us back to Toronto, I want to let you know that me and my team and my lab are very committed to reconciliation. And so, and I've been working in this space now for a long time, but we have worked with tobacco as a sacred plant for many, many indigenous communities across Turtle Island. And so in working with that, when we are talking about things today, I'm really talking about commercial tobacco use. And when we're talking about commercial tobacco use, we've been working with several First Nations, including Inuit and Métis, and we've developed and co-developed toolkits for addressing commercial tobacco use. This is using OCAP principles. It's free for people to use. It's on our website. And it's not a pan-Aboriginal solution, but it certainly guides some of the principles and can be used by various nations to address commercial tobacco use. We also implement the STOP program in partnership with several Aboriginal health access agencies or Indigenous health agencies, currently 15 organizations, spanning 34 total Indigenous health sites. And as a result of that work, we work very closely with the Center of Excellence called Shkabe Makwar at CAMH. And through our work, we also have anti-racism, anti-oppression working groups, and a sex and gender plus working group that is continuing to inform our work. So as we are going along, take a moment to identify the land where you're joining us from today. And if you're unsure, there's a link in the slides on whose land to find out where you're at. And feel free to type it into the chat and introduce yourself. And then the other thing is, it's always important to start reflecting and looking at our relationship to the land. I'm an immigrant settler to this country, and I have benefited greatly from the privileges that have been afforded to me as a settler and in my position as a physician at CAMH. So it's really important to reflect on it and then reflect on the history and the stewardship of the land, and I would say water as well. And then thinking about how past and ongoing oppression and colonialism really affects our Indigenous communities and our own lived experiences, and especially relevant when we are talking about this intersection of the commercial tobacco use and the opioid epidemic that is raging through this country at the moment and across the island. So feel free to type into the chat, and be really interested to hear and see where people are joining us from today. Okay, seeing none, we'll see how it goes as we go along. But the learning objectives that I hope to cover in the next little time that we're spending together for the next hour is really three things: the relationship between tobacco and opioid use, the harms associated with concurrent tobacco and opioid use, and what approaches that we can take to help people who are concurrently using both. So let's start off with a regular, situation often seen. We're going to meet somebody called Jane, a single, postmenopausal, 51 years of age, and stabilized on methadone 100 milligrams per day for the last 2 years, has level 6 take-home doses, currently smokes 40 cigarettes a day, and has come in to quit smoking. So this is where I'm really going to ask you to chat, and I don't know if it's only me who can't see anybody typing into the chat, but could I ask Anastasia or Galit to type into the chat to see if I can see? Yeah, that's great. So Anastasia, I can see your chat coming through. So these are the questions. What consideration should be made in a treatment plan if Jane wants to quit smoking? What is your first choice of smoking cessation medication? And when will you see her for follow-up? What is the second choice if she doesn't respond? So feel free to type. Okay, so we have somebody, Arthur saying Champix or Varenicline would be your first choice. Great. Anybody else? Do an EKG to see what's going on. Her age, she's on methadone 100 milligrams, getting to that upper limit where potentially she could have a prolongation of her QT interval. Or consider group support or psychosocial. Absolutely. Anything else? Okay, so we've really got there's some testing that you would do, and interventions about medication and some sort of psychosocial support. So that you've got we've got the elements of addiction treatment right in there. And so in many ways, thinking about treating the addiction to tobacco is similar to the addiction to opioids is not a bad frame, or any other substance, right? I mean, if you look at all substances of abuse, pretty much they all come from they all come from plant products. They are derivatives, of course. And there can be synthetic versions of that, but technically, naturally occurring, all come from plant products, no matter what the drug class, except I think the cane toad. Otherwise, everything is a plant product. They all have to be consumed, which means there's an appetite for them and there's a consumptive pattern, which goes in a periodic way, which is used in a way that is it keeps the person out of withdrawal, and also there's an element of tolerance. So no matter which drug you talk about, it has that pattern of a quantity and a frequency with tolerance and withdrawal, and going from impulsive use to compulsive use. So that seems to be common. And so as we are looking at substances of abuse, or people that use substances and get into trouble with them, we have to pay attention to that. And the toxicity of the substance has a lot to do with its inherent properties. And so its overdose risk, for example, is very high with certain types of opioids. But overdose risk is very high with nicotine, and it can happen with poisoning, with people are not tolerant, getting exposed to large amounts of nicotine. It used to be called green tobacco sickness. So that is one aspect to keep in mind. There's toxicity, and then there is addiction. So here's the public health impact. If you take a look at what is killing most Canadians, uh, smoking accounts for about 46,000 deaths. That's the size of Belleville, Ontario, being wiped off the map every year. And that is what tobacco-related illnesses cost. And that's more than alcohol, opioids, other illicit drugs, HIV, motor vehicle accident, Hep C combined. So the total number of deaths caused by smoking is the number one addiction. It's not the most frequent addiction, because now alcohol has taken over as the prevalence has dropped down, but certainly is up there. And we have about 16 million Canadians who have at least one smoking-related illness. Huge economic costs to society. But the good news is that taking a comprehensive approach to the use of tobacco, where most people who die from tobacco are dying because of the smoke. It's the route of administration and the composition of cigarettes that is killing people. But overall, the prevalence has really dropped from if you look at back in the 60s to now, where half of Canadians smoke, to just 1 in 10 now in 2020. We have about 11% of Canadians currently smoking cigarettes. And we've got prevention has worked. Most Canadians have never been smokers. So, but you do see this drop is more in men, than in women. Although we still have more men smoking than women, it is still there. But that drop is not equitable. You have higher smoking rates. So as a population, everybody has benefited. But certain populations haven't. Young adults haven't. Indigenous populations continue to have high rates. Immigrants from high prevalence countries, those with concurrent mental illness and or substance use, very high, and those with chronic pain. And when we take a look at the rough estimates, we think anywhere between 75 to 94% of opioid users smoke, and is the leading cause of death amongst them after you account for overdose deaths from toxicity. So what is it when we take a look at a deeper dive of the various data? Globally, 85% of individuals reporting OUD treatment smoke, and it is much higher, as I said, than the general population. Think about that inequity, and in fact, that's what we say. The bulk of smoking is now happening in the population that can least afford to smoke. 92% of individuals using heroin and not in OUD smoke cigarettes, and 95% of syringe exchange programs participate smoke cigarettes. One of the things I've always said from a harm reduction, what about having a cigarette exchange program? Because you're giving if somebody traded in, they're trading in a product that contains about 7,000 chemicals, 60 carcinogens. Most of them are not safe in any form for human consumption, but we do have clean nicotine. We could give people clean nicotine instead. So, if we working in substance use and harm reduction could think about this in a different way, I think we could be helping a lot of people not come to harm from their smoking. So, as I said, it's very high in people in methadone OUD treatment programs with methadone. Methadone itself increases cigarette smoking. Al-Qaeda worked with us, and he was a PhD student. He did the study with us as a postdoc, and really looked at that interplay between being on methadone, opioids, and smoking. And so we do know that smoking increases methadone self-administration and reinforcing properties. So when you have a person who is on methadone, and even if they're stable, that smoking has a great relationship with the methadone. And patients will tell you they smoke for all sorts of reasons while they're on methadone. They'll smoke as a way to bridge themselves as a dose, before they get dosed, so they use it to manage their withdrawal as the levels of methadone are dropping. Or they'll use it when the methadone is peaking to prevent them going on the nod and have a cigarette instead. So it's an interplay between that, between methadone and and nicotine. Okay, so when we take a look at the population, there's often, as providers, we often say, "Oh, well, they're not interested. They've got other things going on, more important things going on." And in fact, I started my career in addiction medicine treating pregnant substance using women who used opioids, and had a whole program for them. And it was very interesting as I went on and had a very successful program. I noticed that one thing we were never able to help them with was with smoking. And smoking has a huge impact on the woman as well as the fetus, and it accounts for a lot of the problems that you have in pregnancy. And is not the opioid; it's the smoke. But that's what got me interested in it, and I realized that this addiction was more prevalent, was harder to treat, and really one of the things is that we were not paying attention to the levels of motivation that were present in the population, just because we made this assumption that they had other things going on. And they made many prior attempts to quit, and again, multiple quit attempts is an important piece. So it's about listening and understanding where the client's at with respect to quitting smoking. So when I look at addiction and their solutions, it's no different for opiates, it's no different for tobacco. We have a drug and a stimulus that has a desirability that people want to use, and use repeatedly and compulsively, as we talked about. There's an individual who has a vulnerability that is determined by their life experiences, by their genetics, by their by their own psychology, their own identity, etc. That is happening in the interplay between the environment in which they find themselves, the financial, social, economic, and cultural environment. But a lot of that is determined by the vector or the dealer, who has every role to play in either making that drug addictive, harmful, etc., and marketing it to the host in such a way that it makes it desirable to them. So you see, so in this case, it's the tobacco industry that, and in their own internal documents, say that they have a specific target of people who can least afford to smoke, and who they call the poor and the stupid. So and those are our patients who they're talking about. So when we are trying to help people get over any addiction, it is not just substituting with one, like just substituting with nicotine replacement or something like that. It's really changing the host's, like the individual's relationship with that drug, as well as with the dealers and the environment. So taking a developmental biopsychosocial approach that you would take towards any other addiction needs to be brought to the same issue of smoking as well. And I don't want to bore you with this, but it's exactly the same brain regions that we also understand that go from where people want to seek the drug and use it to having to use the drug and then having great difficulty staying stopped because their brain circuits have got into a loop where they can't go without the drug. So this is just at the individual level as we better understand the brain circuits involved in addiction. This is really why people have great difficulty staying stopped. Okay, so that's what we understand about addiction. And we're going to just talk about the harms and the impacts. So clearly there's an association with smoking status is really associated with higher rates of relapse and poor quality of life and obviously premature mortality. In pregnancy, worse outcomes, as I mentioned. And of course, it is the leading cause of death among persons with opioid and other substance use disorders, notwithstanding the high rates of death that occur from a toxic drug supply. And again, you take a look at the data, death rate for smokers with substance use disorders 4 times higher than non-smokers. So it is taking people away. So, if you think about it, yes, we should have naloxone program, we should have people into treatment, but it's the same thing. You can help people stabilize on OUD, you manage all of that, but you also have to help them quit this other addiction, which is more likely to kill them. When we do, and I used to do some groups with individuals in the residential program, we used to have this question of drug of choice. And it was very fascinating. We would ask people, what's your drug of choice? And those people would say alcohol and cocaine and what have you. And then I would just ask the question, so let's start about, but which was the first drug you ever started? Tobacco. Okay. And which is the last one to go? Tobacco. All right. So now what's your drug of choice? Let's think about that. The first to go, first to come, the last to go, most likely to kill you. How is that not your drug of choice? And again, those are really important questions to ask because it helps people understand how subtle this addiction is and that how it can kill them. So we have lots of challenges because there are smoking cessation interventions available. Most provinces across the country will cover varenicline and bupropion for a limited amount of time, 12 weeks. And different provinces have different NRT. In Ontario, through the STOP program, people can be eligible for nicotine replacement of up to 26 weeks. And if they've actually quit in the last month with that NRT, with whatever dose they need. So the dosing availability in NRT is similar to the dosing that you could use for methadone. You go up to the dose that the person needs. In fact, that's how I learned how to dose nicotine replacement, because I used to dose people with methadone till they were comfortable. And that's what I do with nicotine replacement. I dose them till they're comfortable. So despite all of that being available, and despite that I could potentially give somebody 1 year's worth of nicotine, less than 40% of OTPs provide smoking cessation counseling. Fewer than 1/3 provide treatment, medication, clean nicotine, less than that. And we have pro-social norms that providers and patients lowers the provision of tobacco treatment services. When we look at the STOP program in Ontario, we have about 18% of the addiction treatment offering it, and it's free for them to do it. Again, it is really, now there are some real good examples of addiction treatment providers doing a fantastic job. They provide the treatment not only for their patients or their clients, but also for their staff and also for the surrounding neighborhood. So it is possible. There are examples of it being done. It is doing, but for the bulk, these are the challenges. And again, when people are smoking and the culture of smoking is around, it makes it that much harder for people to be successful. So you know that if somebody lives in a household where somebody smokes, they're half as likely to be successful. And that's just common sense. At the individual level, clearly they have a high burden of a chronic illness. They may be having Hep C, they have other things like that go on, and they have to manage all sorts of other issues, appointments, and other social determinants of health. And so they may or may not want to have one more medication put on. They also have psychiatric comorbidities. people have been traumatized. A lot of high ACE scores. And here's the thing with ACE scores. Somebody with an ACE score of over 10 is twice as likely to become tobacco dependent as an adult. And that is what is thought to mediate some of the complications in physical health, like getting lung disease, etc. But they also have people with opioid use disorder have psychiatric comorbidities as well, and they often use tobacco as their buddy, their friend, as a way to manage negative feelings, etc. And so we also have, as I mentioned, with people on MMT with chronic severe pain, and pain reduces the effectiveness of quitting smoking. It's not well studied. We have been doing some work through the STOP program that we can show that people with pain are less likely to quit. And we have colleagues in Rochester, New York, who are also showing the same thing. So as we look at people as opposed to their diagnosis, we start seeing all these clusters. And so working with them to think about their tobacco use and help them on that journey requires us to pay attention to what's happening at that individual level with the burden of chronic illness, psychiatric comorbidities, and pain. Here it's getting a little bit more technical, going into the brain itself. Nicotine, as we know, releases endogenous opioids by binding to nicotinic receptors of neurons that contain opioid peptides, and therefore make nicotine much more addictive. Naloxone, naltrexone can precipitate nicotine withdrawal and increase cravings. And as I said, opioid agonists like morphine, methadone can also decrease nicotine withdrawal. And they are more likely, as I mentioned, smokers with OUD smoke more at peak opioid effects and increase the number of cigarettes a day, CPD, cigarettes per day, with higher opioid use. Now, what is the other challenges? There are interactions between nicotine and opioid medication, which I talked about, and therefore you get increased smoking or desire to smoke within that 2 hours of methadone administration, and it's linked to that elevated euphoria. There's also the problem of low adherence to treatment in OAT patients or in OUD patients. 48% for nicotine replacement, 34% for varenicline. And OUD patients fail to initiate or adhere to their prescribed pharmacotherapies. And that is in keeping with a lot of adherence issues. So, medication is not going to work if people don't take it. So those are all the challenges. And as we are thinking about Jane, really think about, did we really think about all of these issues in helping them when they're trying to quit smoking? So with that in mind, I'm just going to jump into the treatment approaches that can address concurrent tobacco and opioid use. So these are the behavioral interventions. There are low behavioral intensity behavioral intervention, motivation engineering, which we all know, and contingency management. So let's take a look at each one. So every OUD program should have a structure of screening for smoking. It's called the 5 A's. You're asking everybody about their smoking status. You're assessing their readiness. You're assisting them to get more motivated and providing them assistance, both counseling as well as and medication, and following and arranging follow-up. There are also quit lines in many provinces and states, but they are ineffective alone for smokers with OUD. So simply having this without pharmacotherapy is a waste of time. Because you take a look at that in randomized controlled trials, there's a 0% cessation rate with these methods compared to 13% in smokers without OUD. So if somebody has OUD, this doesn't work. Quitting smoking is hard, but it's even harder in those with people on OUD if you just simply do standard treatment for them. The intervention is not potent enough. They have unstable telephone access if you're trying to do a quit line, and there's low adherence to counseling. With motivation intervention, there's a modest effect. They show low cessation rates between MI and brief counseling. It's not that that much different. And the challenges include low adherence to this counseling intervention. And you need to have staff that are trained in motivation interviewing really well, and that there's fidelity to the model, so which is expensive and difficult to do. What does seem to show some benefit is contingency management. Using financial incentives show potent short-term absence effects, but here's the thing. These significant initial abstinence rates have a steep return to smoking post-intervention. So they can stop smoking, but can't stay stopped. And you need some novel strategies like long-term CM may be needed to maintain long-term effects. And this is just looking at contingency management. This is a systematic review by Bolivar in 2021, looking at overall what its effectiveness across different substances. So stimulants, the effect size is 0.7, cigarettes is 0.78, not so good for illicit opioid use, for medication adherence, 0.75, polysubstance, not so good, therapy attendance, not so good. But overall, there's great effect size for treatment adherence than abstinence. But again, so CM is really one of those things that we don't really provide. But when you take a look at it when you're using opioid use disorder and there's maintenance treatments, you see that overall, you can get a medium to large effect size was observed in 3 of these studies in people with methadone and or buprenorphine. So, it is something that we need to think about how to scale this up in a broader way. And in this other, again, this Ainscott another showed in 2018 showed that contingency management aimed at other substance use in people receiving treatment for OUD, the longest duration of abstinence and the percentage of negative values, CM performs better than control in reducing most substance use. So it is efficacious for cocaine, non-prescribed opiates, tobacco, polysubstance use during opioid addiction treatment, but not for the use for not prescribed opioids. And I think I've seen that primarily what drives that is a combination of the adequate dosing of the opiate agonist treatment and or psychosocial interventions for that. So let's go at the medications now for nicotine replacement. When you take a nicotine replacement or NRT monotherapy, so that's either patch or gum or inhaler, any of those, you get modest cessation effects among smokers with OUD. Adherence is crucial for success. And obviously, there are strategies needed to maintain abstinence in the long term. So in these 2 studies, one with 83, one with 225 people in outpatient settings, you can see that absolute quit rates are low, but compared to the control group, they do much better. So the absolute success is low, but it is really, for a short-term intervention, does much better than control groups. And so really, if you take a look at it, the intervention group demonstrates a 10 to 11% abstinence during treatment, which drops to 5 to 6% at 13 and 26 weeks follow-up. But here's the thing that people don't often tell you. The 1-year successful cessation rate in the population in general is only 3%. So if you are getting that kind of 5 to 6% at 26 weeks, you're doubling what is happening than what is there. And people say, well, that's not a high absolute rate. But here's the thing. Listen carefully. For every 2 smokers you can help quit, 1 of them will not die from a smoking-related illness. And we know that if you can help somebody quit smoking before the age of 40, they gain essentially 10 good years of life, which means they get their normal life expectancy back. If you can help somebody quit at the age 60, when the runway is getting shorter, they gain 3 years, not 3 weeks, 3 years of quality life after that. So it is every little thing you can do to help somebody stop putting those 7,000 chemicals into their bodies improves their longevity and the quality of life. So, and it's not just, living, it's actually living well. So NRT really, where the issue is that in people with opioid use disorder, combination nicotine replacement and high dose patch, 42 milligrams, so two large patches, or 35 or 28 daily, significantly increases abstinence rate over standard NRT dosing. And again, extended doses. And that's why when I started doing this work, I learned how I was dosing methadone to effect, I started dosing nicotine to effect. So every time somebody came in and told me that they're smoking, I asked them, how much are you smoking? And I would bump the dose up till they came back and said, you know what, I can go 24 hours. I don't have any cravings to smoke. The dose is right. I am comfortable. So that's exactly how we dose nicotine. I've been doing that for about 25 years now. And so, but the overall, when you get into studies, you get modest effects amongst people with OUD, and you see in buprenorphine maintained smokers, 54% initiated NRT, completed less than half of the counseling sessions, and only used a small fraction of the NRT offered. And you had 11% with extended treatment success rate and 11.3 in the control group. So no real effort when they did this head-to-head trial. And those on methadone, adherence at 6 months, 48% with NRT, 34% with varenicline, and 34% with placebo. Cessation rates were 8.3% with NRT, 3.7% with varenicline, and 2.2% with placebo. So this really helps us understand that in people who are on OUD, our preferred drug is actually not what you think it is. And let's take a look at this meta-analysis of smoking cessation on people on prescribed methadone, behavioral versus pharmacological treatment for 8 weeks, about 1,400 subjects, 1,300 subjects, NRT and placebo, and additional behavioral therapy. You can see the pooled odds of smokers' absence at the end of treatment is 6. And again, with you add behavioral therapy, there's no significant difference. So nicotine replacement with or without behavioral therapy attained the best smoking cessation rate among patients who are receiving methadone. And so really, it's not varenicline as your first line anymore in non-OUD patients. Yes, varenicline or combination, but we are more likely to use nicotine replacement in our patients. And again, with people on OUD, the sample size patients treated with buprenorphine, about 315, of which 66% were current smokers. Only 33 received smoking cessation. And of those, 15 got varenicline, 1 got bupropion, 20 got the patch, 9 got gum, and 2 got inhaler. The only factor associated with prescription for smoking cessation medication was buprenorphine treatment retention at 6 months. And this is kind of common sense that if people are stabilizing, then you're going to start talking about smoking. And so that's what we do when people are unstable early on in their addiction. It may be just if they are in a congregate setting where they can't smoke, manage their nicotine withdrawal. With no commitment for long-term abstinence, just manage their nicotine withdrawal so they are comfortable and can complete whatever other treatment they need to complete. So this is the other thing. So if people are retained, they're more likely to obviously get nicotine replacement. And patients in office-based buprenorphine treatment have high tobacco use prevalence, but few receive smoking cessation treatment. What are the implications? It means clinics need to really think about how do they shift the culture and systematically help people address their use of tobacco, and what are some of the harm reduction options open to those who are unwilling or not ready to quit. Now, the combination of smoke, which has nicotine, tar, carbon monoxide, a whole bunch of other things, and polyaromatic hydrocarbons, whenever you burn anything, you inhale it, those are actually active in the body. They induce the cytochrome system, CYP1A2, CYP1A1, and CYP2E, and these affect several medications, especially psychiatric medications, especially caffeine. And of course, nicotine has interaction with CYP2A6, and methadone has its own drug induction problems with CYP4, 2B6, and 2C19, and buprenorphine has 3A4. So they all affect different things. And it is important to understand that when quitting smoking, the body does metabolize specific medications differently, like caffeine, like antipsychotics. And you do need to pay attention to that as people are quitting smoking. So we know that methadone administration leads to dose-related increases in smoking satisfaction. So cigarettes taste better and feel much better. And again, similarly with buprenorphine. So when we come back um, to Jane, I think we need to think about what are really the treatment goals. So here you have somebody who's on MMT, 51 years of age, postmenopausal. What is the purpose behind trying to come off cigarettes? Is it for health? Is it finances? Or there's something else? And is the goal a complete cessation, or is it reduction, or are they fine to look at? Look, I just want to get rid of smoke, and I'm happy to be nicotine maintained. So those are some of the things that have to be considered, as well as the time to achieve those milestones. We talked about the interactions to consider when treating concurrent use. So we talked about how the methadone affects the craving. So I often find with my patients who are taking any form of OUD treatment, we often have to use higher doses of nicotine replacement. And so I often talk to people about that. I'm saying, look, we're going to start off with a patch plus some short acting when you have cravings. But if you do smoke, please report back so we can bump the dose up. And that is, it's just like when somebody is using opioids. When they're starting out, they continue to use opioids, and we talk about getting the dose to the right sort of blocking dose. That's what we're trying to do with nicotine replacement. And then we're thinking about what withdrawal symptoms they're having. So the withdrawal symptoms are irritability, poor concentration, hunger, uh, depression, lack of sleep. So if those are what are presenting, then, those are some of the things we need to consider. One of the other things we need to consider in somebody who is at the age of 51 postmenopausal smoking, that woman is at high risk for osteoporosis, high risk for heart disease, and so yes, Tomoko talked about an EKG, but really it's more than that, and you really need to do a cardiometabolic workup on this woman, including a bone density, to see where she's at in her cardiometabolic health. Because also one of the things, as she's starting to quit smoking, you have to pay attention to the fact that she may have an increased appetite. And we all know our patients, when we put them onto OUD treatments, they get an insatiable desire to consume refined carbohydrates, and in fact might gain a lot of weight. Interestingly enough, I see that with people giving up alcohol, and I see that happening with people giving up nicotine, because refined carbohydrates have sugars, and sugars are what actually have been shown to mitigate withdrawal symptoms at one level, but they also are comfort when people are in distress. So it's a complex one. And so it's really important to understand, to prevent post cessation weight gain in this lady, and this woman, is to understand that what is her goal and how is she going to manage her appetite and her food consumption, especially if she has limited income, where dense calories are much more available than healthier foods. So one of the things to consider when you're dealing with somebody like this is to help them understand that if they're buying regular cigarettes at $13 a pack, which often most people are not, they're buying contraband at $30 a week. But whatever it is, that money that if they can save and put towards healthy foods, that's another way to manage that improvement in health. So it's a lot of counseling. I think the counseling is not so much just about their relationship to cigarettes, their buddy, their breakup friend, or whatever, but it's about learning practical reasons and means to stop, and what to do with the benefit of, or what will come from quitting smoking, like assigning money for food, clothing, etc. So that's what we talked about, James, and I would like you to type into the chat how is your approach changed based on this review that we just did. And I'm going to invite you to use the chat again to update your or anything else that stuck out for you. So she's still 51. She's still smoking 40 cigarettes a day. And what are some of the considerations you would make? Okay, I'm seeing none. I don't see anything in the chat. So I'll just come back that in this situation, I think if we have to pay attention to the 40 cigarettes a day, that's a higher level of dependence. And so, somebody who's smoking a pack a day of cigarettes, which is about 20 to 25, when you give them only 21 milligrams of nicotine replacement, in that situation, you're only replacing about 50% of their nicotine needs. You may keep them out of withdrawal if they are locked up in a room where there are no cues, no triggers to smoke, but they're going to be really jonesing for cigarettes. If you give that one patch to somebody who is smoking 40 cigarettes a day, they'll be incessantly in withdrawal, constantly thinking about smoking, uncomfortable, irritable. And so, how I dose people like this is I'll start off with one patch of 21 milligrams for 3 days and immediately bump up to two patches. This is off label, obviously. Have the conversation with people, teach them how not to get into nicotine toxicity, and then bump it up to those two patches per day, and also have breakthrough nicotine replacements, whether it's lozenge, gum, inhaler. That's all provided by the STOP program. Or if they want to buy it, they can get the nicotine mouth spray available. And so what we talk about is saying our first milestone is getting you to 1 day without a single puff. That is the first milestone that you know you're hitting the target with respect to your nicotine replacement. Can the person go 1 full day, 24 hours, without experiencing withdrawal and feeling comfortable? So that helps us. And then the next milestone we're trying to get them to is about 7 days without a single puff. And then we know that we are in that early consolidation of dosing, that they're comfortable, they're over the acute withdrawal from cigarettes, and they're getting on their way to being quit. So, but not everybody is able or willing or wants to quit. And so harm reduction, as you know, is an old concept that comes from St. Thomas More. And very quickly, as I say, it's what you cannot turn to good, you must at least make as little bad as you can. And, harm reduction has been a bad word in tobacco control primarily because the industry fooled people. When the health sector realized that smoking was causing cancer, they said we should put filters on it. And when the filters didn't work, the tobacco industry said, no, we'll just create light and mild cigarettes that will show you they're getting less. And that was actually a scam, because all it did was fool the machine testing the amount of smoke going into people, but not the smoker, because they put holes in the filter that the person would cover up when they smoked. And actually, the cancers that they got were worse. From the lung cancer we have now is worse because of the advent of filters and light cigarettes, because people have to take deeper drags. And it's a harder cancer to treat. So really, what we're really looking at is we need to move away from the industry defining what harm reduction is, and for healthcare professionals and people with lived experience to decide what harm reduction is. Okay, moving along. Cutting down itself doesn't reduce the exposure, but it's a good behavioral indication that the person is wanting to move things through. But really, combining cutting down with clean nicotine as a crossfading, as I mentioned, is one way to do that. The other one is at a population level, and these are studies done, that reducing the amount of nicotine in cigarettes, you can get decreased uptake of regular smoking, decreasing the amount of people who smoke, and basically you're making cigarettes less addictive. I'm going to go ahead because we only have 10 minutes left, and I've got a ton of stuff to go. But what I do want to share with you is that we do have lower risk nicotine use guidelines that can be used by healthcare professionals when talking to their providers. There's the evidence brief there. There are the guidelines itself, and then there's a patient-facing resource so that they can make an informed decision if they are wanting to continue to use nicotine, what are the safest ways for them to get nicotine. So, and we've created this chart to tell people what are the safer forms which have what's in it. So, for example, there is no tobacco in e-cigarettes or nicotine replacements. They do have nicotine, But again, we talk about the level of addiction risk. We talk about the harms on the lungs, cancer risk, cardiovascular disease, and reproductive health of the various formats. And of course, the one that is all the rage is e-cigarettes. But here's a problem with all our policies. Overall, the benefit of e-cigarettes are not being accrued to those who currently smoke, because what has happened is young people who are not at risk of smoking cigarettes are picking up e-cigarettes, but people who are unwilling or unable to quit with evidence-based treatment aren't switching over 100% to e-cigarettes. So that's the problem, because we've known for 10 years that the amount of toxicants in an e-cigarette are that much lower. You can just look at this table, and the slides will be available. But if you take a look at those last two, the cancer-causing chemicals that are inherent in tobacco are 380 times less in an e-cigarette puff than in mainstream smoke. So and 450 times less of acetaldehyde. Just the reduction in exposure is astounding. If this were for any other substance, we would be running to and getting the population switching over to this and banning the really toxic exposure substance. And pretty much this slide just shows that these various products, there are different lines from different e-cigarette products, that basically the blue line is cigarettes. Pretty much that slope of the line, how quickly it goes up, is getting pretty close in e-cigarettes, which means it is able to substitute for cigarettes like never before. It's not 100%, but it's pretty down close. Lots of trials that have been done across the pond for e-cigarettes for cessation, and it's better than NRT. Nicotine e-cigarettes are better than non-nicotine e-cigarettes, and it's better than behavioral supports. And so overall, the recommendation is that e-cigarettes should be used for cessation. The problem in Canada is that we don't have an approved e-cigarette for cessation. This is a recent project. We're just going to be launching it fully, the results of it, on World No Tobacco Day on May 31st next week. It's called Project Vector, and it is about the e-cigarette and toxicity on health. And there's some resources for frequently asked questions about it and harm fact sheets. And this provides a decision tree for people to become leading a smoke-free life. Doesn't mean a nicotine-free life, but a smoke-free life. And these are vaping harm reduction tips. I told you about the guidelines at a glance and the tips for harm reduction, about completely switching, use cartridges with less nicotine, and follow the instructions, and use only devices authorized for sale in Canada that do not make any modifications to the product. So this is the STOP program. In the interest of time, I'm not going to go over, but I can just let you know that the STOP program, we've been around since 2005. We've treated over 400,000 Ontarians with nicotine replacement across the province and continue to do that. We've made it accessible through a web-based portal called Stop on the Net, free online direct-to-patient program to support adults in Ontario to quit. And again, they register online, they questions about who they are, and we mail it out to them and do follow-up, all automated. And this is what it is. And then that's where we help even healthcare providers implement it. And many, as I mentioned, we have training programs for individuals to do this. So I'm going to just switch over all of this because we do have only 5 minutes. And I can let you know that when we take a look at in the STOP portal across primary care basements, this isn't family practice. If you look at last 30 days of opioid use, we have about a 16.2% of individuals who are engaging in the STOP program have reported past 30-day opioid use. And that is an interesting fact, because these are people not coming through it through addiction treatment programs, but through primary care. So if people are using opioids at baseline, negatively associated with 30-day abstinence at 6 months. And again, these are in primary care settings. We also do consultations in Toronto for people who are heavily dependent, complex addictions to tobacco, have to have cancer and smoke, have mental illness and smoke, have on OUD and smoke. We can see them in consultation at the Nicotine Dependence Clinic at CAMH, and you can make a referral through Access CAMH to them. And with that, I'm going to stop because I know we're getting close to time. I want to acknowledge my team. We are an integrated team of clinicians, researchers, educators, policymakers, all working together to address the addiction to tobacco in Ontario, Canada. So with that, that's our team. And open it up for questions and discussions. And feel free to type in your questions, if any, and or we could just get rid of the slides and open it up for discussion.
I think it might just be a little bit
Yeah,
late.
I know it is.
I'm sorry about that.
No, it's okay. If there are no questions, there are no questions. That's fine.
Yeah.
All right.
Was
Okay.
there anything that you wanted to say before we?
No, it's just, I hope this got you to think about how, if you do treat people with opioid use disorder, that pay attention to their tobacco use. There are if you're in Ontario, there are resources available to them, and that it's accessible either whether in Toronto or anywhere else in the province.
Great. Thank you so much.
Okay.
Yeah. All right. Thank you for speaking, and thank you everyone for attending this last session of the day.
Great. Thank you.
Thank you.
Bye. Bye. Good evening. Bye.